Hello, I'm Graham Foster, and it's my real pleasure to present a summary of the first day of the Paris meeting. I think we all recognise that our year begins with Patrick Marcelin's Paris meeting, and it's always a pleasure to be invited. So, Patrick, thank you very much indeed. Normally, the take-home messages session is a little bit daunting for a presenter because you're looking out at an audience of your friends and colleagues and presenting their own data back at them, and you could always see them wincing. So in some ways, I'm quite pleased that I'm doing this remotely, and I hope that next year we'll be able to meet face to face. So these are my conflicts of interest. And let's start, and I'm afraid we always need to start nowadays with COVID. And Thomas Berg began today by looking at the impact of coronavirus and the liver. And there are clearly two issues to consider. The first is what the coronavirus itself does to the liver, and then what liver disease does to COVID-19. And Thomas provided a masterly overview of the current state of the art. We know that when you catch coronavirus and develop COVID, the severity of the hepatitis is a poor prognostic factor. We know that most people develop a hepatitis followed by very often a cholestatic picture. And we're starting to understand a little bit more about the pathophysiology of that. Thomas reviewed the liver biopsy findings. This, I think, was a very important study, and it highlighted the fact that there are two liver injury sessions. The first session is the early session where there is lobular and portal inflammation, and that we believe may be characterized by infection directly. And there are some interesting models as to how that might occur and some fascinating research, I'm sure, to be done. There then seems to be a second phase, which is very often characterized by this vascular thrombosis, and we think that is a feature of the inflammatory response. Many of you will, I'm sure, have been looking after patients on ITU in the pre-COVID era, and we always used to talk about an ITU hepatopathy. Well, we're certainly seeing that with the coronavirus, and we're certainly seeing it in a very significant number of patients. And sadly, it's a poor prognostic feature. The other aspect that Thomas touched upon was the impact of liver disease on COVID. And what we know, I'm afraid, is that our patients with cirrhosis, particularly decompensated cirrhosis, do very badly if they become infected. We also recognize that obesity is a very poor prognostic factor, and obesity does seem to increase COVID mortality. What Thomas reviewed was the data asking the question on whether the increase in COVID mortality in people with obesity and fatty liver disease is related purely to the obesity, or whether the fatty liver disease plays a role. And the consensus at the moment is that very strongly it is the liver inflammation from the fatty liver disease that seems to be an independent factor for the more increased mortality and morbidity. And we saw some fascinating data looking at gene expression arrays. And I think intriguingly, the gene expression profile in people with significant coronavirus is matched by the inflammatory pathways that seem to be activated in metabolic associated liver disease. So there is an interesting interaction here. And I suspect that studies as we go forward will reveal new insights into not just COVID impact on the liver, but the pathophysiology of fatty liver disease. So this certainly seems to be a very interesting area and potentially an area for some significant advance. And perhaps one of the byproducts of COVID might be some insights into metabolic associated liver disease. And that is probably the piece of good news from COVID, because when we start looking at the impact of COVID on our treatment programs, it's very clear that we have fallen a little way behind. Antonio Craxi reviewed the current literature, which is a fairly depressing review, I'm afraid, because it's very clear that our plans to eliminate hepatitis C have been dealt a very hard blow by the coronavirus pandemic, and it is going to take us some time to recover. Antonio tried to sweeten the pill by emphasizing some of the new approaches to hepatitis C care that might bear fruit in the long term. But I'm afraid for the hepatitis C elimination program, it's going to be quite a long, hard road to recover. Then I'm afraid was also the theme in our next talk, looking at hepatitis B elimination. And Seng-Ji showed us some really fairly depressing data, I'm afraid, illustrating how difficult it is to get on top of hepatitis B. We have, of course, a vaccine, but sadly, despite having a vaccine, we're still seeing large numbers of infants infected. You can see from one of his slides that I'm showing you here how in many countries we're just not getting the first dose of the vaccine administered in a timely fashion. And that, of course, means that the hepatitis B pandemic is going to increase. Never mind COVID, we've got a problem even without COVID in moving to hepatitis B elimination. And if we look at our performance targets so far, for hepatitis C, we were making a bit of progress before COVID. But here, as you can see, for hepatitis B, we're really way off track. So I'm afraid the bad news is that hepatitis B is quite a long way from where we want to be. And I think that's going to require a really renewed effort if we're going to get this back on track. Maria Booty lightened the load. I've been a little bit depressing, I'm afraid, talking about the impact of COVID and hepatitis B. But Maria gave us a little ray of sunshine, talking about TAF, confirming that now in long-term real-world studies, it seems to do what we've always suspected it should do, and that is to improve the renal and bone profile and to suppress hepatitis B replication. Excuse me. TAF, of course, is long-term. This is maintenance, and what we're really looking for is cure. We have curative therapies for hepatitis C. We'd like to see the same for hepatitis B. And that, I'm afraid, is going to require a lot of drugs put together. We had a fabulous remark from Fabian Zulem, who went through the drugs that we have available. He emphasized the combination therapy, combining replication inhibitors, antigen reduction drugs with immune stimulation. And he bedazzled us with an array of new agents, all of which are currently in trials of one sort or another, some of which are at a fairly advanced stage. I'll just tease you with a couple of what for me were the highlights. This is the Janssen triple therapy, a silencer RNA, a capsid assembly modulator, a nucleotide therapy. And you can see here that we're starting to see some really quite impressive impact on hepatitis B surface antigen levels with significant reductions in both E positive and E negative patients. So we are starting to see the first hints that a collection of different drugs targeted and working together will produce the sort of benefits that we're all hoping for, which is a sustained reduction in surface antigen, leading eventually to suppression of viral replication, loss of the virus, and we hope eventually cessation of treatment. So I think for hepatitis B, there is a little bit of good news on the horizon starting to come through. And we're starting to see more than just direct antiviral agents, but we're also starting to see some immunomodulatory studies. This was more data that Fabian presented, looking at anti-PD-1 blockade. So I think for hepatitis B, we are moving to a slightly better place. I would just apply a personal note of caution here. We in the UK had the misfortune to be involved in a trial with a RIG-I inhibitor. This tragically led to the death of a patient, and Patrick Kennedy and I spent most of last Christmas anxiously chewing our fingernails as over 30 patients in London were hospitalized at various stages. With Kosh Agarwal, we had a number of people that we were looking to put on a liver transplant program. And it took many, many months for all of those patients to recover, and a lot of heartache from a lot of us. And tragically, one of those patients succumbed. So whilst we rush to improve management of patients with hepatitis B, whilst we rush to get these wonderful new therapies into the clinic, I think we need just to be aware that these come with a health warning. Not all drugs make it to the market. Not all drugs are as safe as we think they are. And we do need just to be a little cautious and temper our enthusiasm for clinical trials with novel agents in a disease where we already have pretty good therapeutics. Of course, a disease where we don't as yet have very good therapeutics is hepatitis delta. And Professor Tamandi summarized the situation in Asia, which is becoming a real hotspot of hepatitis delta. And in Europe, I'm afraid, as George Papatheodoridis reminded us, a lot of hepatitis delta is moving. And this is data from his talk looking at the impact of migration on hepatitis delta in Europe. And you can see that in his population, looking in Greece, the majority of patients with delta are immigrants. So I think as immigration increases, and I'm a great believer in immigration, I think it enriches us all, and I think we all have a duty to look after those who, through no fault of their own, have been placed in precarious circumstances through acts of war and other catastrophes. It is sobering to think that we will need to evaluate them very carefully and manage their viral infections in an appropriate fashion. And George, I think, made the point very clearly that this is not going to be a trivial process. I said at the beginning that Delta is tricky to treat. We were lucky to have Tarek Asselah presenting the current state of the art. We're all getting very excited by bulevirtide, which is now licensed and starting to become increasingly available in Europe. You can see the data here, combining it with pegylated interferon and the really very impressive response rates. We're still not, of course, quite sure how long to use it for. We don't have all of the answers, but it is very encouraging to see some options for our patients with Delta virus. There are other alternatives coming up. Lefarnib is inching its way forward. It has proved a little bit tricky to get the dosing right, but with ritonavir boosting, we're starting to see clinical studies moving forward that look very promising. So I think we do have more options for Delta virus coming. That, of course, leads to the problem of what do we do today? Heine Wiedemeyer is in an ideal place to tell us how to go forward, and he gave us a very useful summary of his own personal practice. He emphasized that nucleotide therapy in hepatitis delta should follow the rules for hepatitis B. That is, if the hepatitis B is dominating and active or there is cirrhosis, then nucleotide therapy is very helpful. He emphasized the use of pegylated interferon, currently perhaps not quite our gold standard, but the best we have, and talked a little bit about how we're using this in response-guided therapy. You'll know from his HIDIT-1 trial, looking at a variety of treatments for Delta, that not many people manage to stay hepatitis Delta RNA negative, but there is increasing data that using the more sophisticated hepatitis B markers, here we're looking at a core antigen on treatment and showing that might be able to predict response. So I think we're starting to think about response-guided therapy in Delta virus. And Heine finished up with a very useful summary of his own approach to treating Delta virus, reminding us that PEG interferon is still a treatment option, but not perhaps the backbone. And that, of course, may be a good thing, as we know that one of the companies manufacturing pegylated interferon is planning to withdraw it in the not too distant future. But where we're starting to see emerging data is in bulevirtide, and Heine said that his use at the moment is in people with compensated cirrhosis and those with contraindications to pegylated interferon. So we've had a fantastic start to the Paris meeting, as always, full of useful information. Really good to hear from colleagues, seeing the updates in these rapidly changing areas. And we look forward to more information in 2022. And I really hope that on that occasion, Mr. Chairman, Patrick will be able to welcome us once again with a handshake rather than a virtual Zoom link. And on that, enjoy the rest of the meeting.